Good morning, guys. My screen recorder is giving me trouble today, and I go starting off for the fourth time today, saying the same things again and again. Acute renal failure, and this is how we're going to start nephrology today. UTI are is usually the beginning of my nephrology topic review, but the thing with that is I think it was taken up by Dr. Nikhil. So if it wasn't, just let me know. I will try to. I will do it in the next class or the next topic. I'll take it up as UTI. AKI is something that we don't frequently come across in the casualties as much as we do in the ICUs or even in the wards. Patients usually present with other manifestations, and then we go ahead and diagnose the AKI, or we look for AKI in certain patients who come with a history of other problems. For example, a patient has come with lepto. So we look out for AKI because we know that AKI is one of the complications of leptospirosis, and it is the season to be bit by mosquitoes and to be having Ilijora. Not Ili is in, you know what ILI is, guys? ILI is influenza like illness, and that's what's going around, right? And in Kannada, it is a rat is called Eli or Ili. If I'm not, please correct me if I'm wrong. And yeah, only when you see it, it's very funny. So in front of all the, in front of at least one lift in HRC and IMS, they have written only for Ili, fever, and SARS. So you really wonder whether it's leptospirosis. That is what Ilijora is in Kannada. Okay, rant over. Let's get back to AKI. So AKI is a functional or structural abnormality of the kidney manifested within 48 hours, determined by blood, urine, or tissue tests and or imaging studies. There's something called the Rifle criteria for it, and it tells us about the risk to kidney injury if the creatinine has gone up by 50 to 100%, or if urine output has dropped for more than 6 hours. It is kidney injury when there's an increase of the creatinine by 100 to 200%, or if urine output has dropped for more than 12 hours to less than 0.5 ml per kg per hour. It is kidney failure when there is an increase of creatinine of more than 200% or more than 4 grams per deciliter, or if the urine output is less than 0.3 ml per kg per hour, or anuria for more than 12 hours. These are different stratifications for the kind of like a stages of kidney injury. So first is a risk, then it's the injury, then it's failure, then loss of function, and end-stage renal disease. End-stage renal disease and loss of function will not come into play right now. I will be talking about the first three. Okay, and so this is the Rifle criteria, the staging. Okay, so this is for you guys to remember that if there's a 150 to 100% rise in the creatinine, doesn't mean it's AKI. Or I mean, if it's less than 50% rise, it doesn't mean it's AKI. But of course, and if there is a drop in less than 0.5 ml per kg per hour for more than 6 hours, then it could be AKI. But you have to wait and see. And this is a golden hour of opportunity for us to make sure that we correct the cause, figure out the cause, and then correct the cause of the AKI so that the patient doesn't go into injury. If the patient comes in this state, we should make sure that the patient doesn't go into failure, because if the patient goes into failure and if you still don't figure it out, that's when eventually they land up with ESRD, that is end stage renal disease, which we don't call anymore. I'll tell you that about that in the CKD slides, but this is what we are trying to prevent. So before the complication becomes permanent, we must make sure that we we reverse the problem. So AKIs are either pre-renal or intrinsic or post-renal. This is also intrinsic renal failure is also called like renal failure. Pre-renal, renal and post-renal failure. Pre-renal is the most common, accounting for about 60 to 70% of the AKI. We will go into the details of that. I just to tell you that intrinsic renal failure is usually associated with either tubular cell injury, acute interstitial nephritis, or acute glomerulonephritis. Tongue twisters. Then you have post-renal causes in about 5 to 10% of the patients. Those who go for an intrinsic renal failure are also somewhere in between. So if you figure out a cause, you should be able to treat it as much as possible. If it is an untreatable cause or if it's a progressive cause, there is a way to delay the progress, if not completely halt the progress. But if it is pre-renal, most of the times, if you figured out exactly the cause, you should be able to completely reverse renal function to normal. They will be at risk even later on of developing the renal failure, but for that particular point in time, if you figure out the reason and if you treat the reason, then you should be able to completely get rid of the AKI. Okay? So again, this was a nice image that I thought would be really good for you guys. So pre-renal causes, true volume depletion, as in any reason for volume depletion like diarrhea, vomiting, bleeding. Okay? Effective decrease in the effective circulatory volume, like in edema, the patient is completely wet, you have ascites, you have pedal edema, but the efficient circulating volume is reduced. And then you have renal vascular disease or NSAIDs that can predispose to pre-renal failure. Next thing is renal failure. So renal failure can happen in acute glomerulonephritis, anti-GBM, ANCA, vascular problems and tubular interstitial diseases, which we will talk about later. It's pretty intensive and it's pretty confusing also to talk about it. So for the next topic, if I will not be able to finish all the slides of this today, I will split the class into two like I usually do, and I will take the classes accordingly. So maybe 2 classes later, I would really like for you guys to read up the interstitial nephritis and acute glomerulonephritis and all of those things, and then go through my slides, and it would definitely then it will click properly for you all. Okay, and then you have your post-renal causes, of course. Excuse me. That is obstruction and ureters. Obstruction of the ureter, the gallbladder, at the level of the prostate, at the level of the urethra. Okay. This is the pathomechanism of renal failure. If there is or pre-renal failure, to be more specific, if there is decreased true or effective circulatory volume, there can be an activation of central bioreceptors, which stimulates the production of angiotensin II, antidiuretic hormone, and norepinephrine. So what happens with antidiuretic hormone? It says it in the name itself. ADH is antidiuretic hormone. It will prevent the patient from peeing. Antidiuretic. Tender coconut causes diuresis. What else causes diuresis that you guys will know about? Tender coconut will. Drinking plenty of water is going to cause diuresis. Hyperglycemia is going to cause diuresis. Okay. Antidiuretic hormone is going to not allow you to pass urine, so you will retain. Then you have norepinephrine, and you will have angiotensin II, that is increase in production. All of these cause vasoconstriction and mesangial cell contraction, and along with these is preferential constriction of the efferent arteriole. This autoregulation, there could be some nitric oxide also that plays a role, and all of these bring about a reduced glomerular filtration rate, a decrease in the GFR. If there is less blood flowing through the kidneys, then obviously it is not going to make enough urine, and that is how the antidiuresis happens. So pre-renal kidney injury, most common cause of AKI. Precipitating cause is renal hypoperfusion due to any reason whatsoever. It could be a reduction in the ECF, it could be ECF is extracellular volume fluid, a decrease in the effective circulatory volume as in sepsis, congestive heart failure, and cirrhosis. It could be a reduction in the glomerular capillary reperfusion, that is in the form of ACEI use, ARB use, and NSAIDs. All 3 of these can cause pre-renal failure in patients who are predisposed to a pre-renal failure or in continuous use. Okay, with continuous use, all of these drugs can cause AKI. So it's really important when patients are see, NSAIDs you are very, very sure about, but then a lot of us prescribe telmisartan, we prescribe lots of drugs, telmisartan, olmesartan for elderly individuals or individuals who have hypertension. But the important thing is to work up the patient a little, maybe 1 or 2 weeks down the line, to check if there is a raise in the creatinine, or inform the patient at least if you find that you are retaining fluid, if you find that you are not peeing enough, just inform me at least. Okay. Initially, the kidney parenchyma will be intact and it will be functional, and it will attempt to maintain the GFR and the blood flow by altering the vascular tone of the afferent and the efferent arterioles of the glomerulus. It can be rapidly reversible. Most importantly, it can be rapidly reversible. There can be renal hypoperfusion. If it further worsens, it will cause a neurohormonal cascade like I showed you earlier. it will cause afferent arterial dilatation, that means more blood will try to flow through the kidneys, and efferent arteriolar constriction. So, less blood will leave from the kidneys. As much as possible, it is trying to maintain the GFR. Okay, that is initially, that is called a hyperfiltration phase. Okay, again coming back to the causes, vomiting, diarrhea, glycosuria, polyuria, hemorrhage, diuretic use, over enthusiastic diuretic use, NSAIDs, ACIs and ARBs. The main signs are of course I always tell you guys, when a patient walks into casualty or is wheeled into casualty, the first thing that you're going to see while you speak to the patient is learn to multitask. Okay, it's a real tool right now. Remember again, one more COVID gyan for you guys. The risk of transmissibility from a patient to you, even if a patient is COVID positive to you, is minimum if you wear the right gear and if you wash your hands right after and if you minimize examination. I am not saying you do not examine the patient at all, that is never going to be the case. We are always going to have hands on the patient forever and for always. We can never avoid that. Clinical examination is very, very crucial, but try to minimize looking into specific things at a time. So, when a patient comes in, while you are speaking to the patient, take a pulse and have somebody take the blood pressure, or while you are speaking to the patient only, try the BP cuff. Do not be like standing there and what's your aim, like how you guys take case in rounds, in wards. Right now, it's okay for you guys to do that. We're totally okay with it. But as the days go by, you should be quicker and it should go hand in hand that you do your clinical examination and your clinical and your history taking at almost the same time, and pause in between to record your significant and important findings. But you have to have the flow so that you can quickly examine the patient. They say 15 minutes, but we have restricted to as much as possible, keeping examination to the minimum of about 10 minutes, contact with the patient for 10 minutes, and quick history, quick examination, and make a quick diagnosis. So, it really has to be hands on and you guys will have to pick it up. So, as you check the blood, as you check the pulse, if there is thready tachycardia, if there is a thready pulse with tachycardia, okay, you know that this patient is having a dehydration. Before though, if the patient is having a normal pulse and if you are still in suspicion of, for any reason, that the patient may have dehydration, what are you going to do? You are going to check orthostatic hypotension. That will tell us that what is orthostatic hypotension. When you check the blood pressure in the first in the lying down position, and then you make the patient stand for about 3 to 5 minutes and then recheck the blood pressure. Any changes in diastolic of more than 30, change in systolic of more than 30 and change in diastolic of more than 20 is significant orthostatic hypotension. That tells you that this patient is going to go in for a dehydration. Next, look for tachycardia. Then comes a reduced JVP, then comes a decreased skin turgor. Skin turgor is not very significant in adults or like the middle population, maybe in very small children and in very elder adults maybe, but not otherwise. Okay. Dry mucous membranes is extremely important for us. You ask the patient to stick your mouth. Again, nowadays we do not even ask to see the patient's mouth as much as possible, because when they say, we say ah, and they go ah, and there is so much aerosol generation. So, what we do is we just assess the eyes, and of course, there are so many other parameters that we can go on. Clinical medicine is going to change so much. Yes, I know some of you are not scared of corona. Even you, again, same thing with us. We may not develop the symptoms, but I am apprehensive about bringing it back home to my elder adults at home. Or for me, if it gets transmitted to one of my other patients, that's not going to be nice. So, we have to be extra cautious. Nobody's trying to be a hero here. Okay, no, neither should you be. Okay, it may have come, it may have infected us also, you don't know. But there's no harm in taking precautions and doing things the right way. There is some even ground that we have to find. When it comes to laboratory findings in prerenal azotemia, you're going to have a blood urine nitrogen and a serum creatinine ratio of more than 20. You're going to have a FeNA of less than 1%. I'll come to what FeNA is in the presence of oliguria. In the urine routine, you're going to find hyaline cas. Now, urine routine is something that we completely undermine, but it's like a gold mine. It's gold in color and it's like a gold mine. Ha ha. So, but urine examination is something that's extremely significant for clinical backing up. Okay, you may not be able to get lots of fancy investigations in smaller centers, especially maybe if you are put in for peripheral postings and all of that. You have to make do with the minimum that you have. Okay, so a urine routine can tell you a lot. Even a specific gravity can tell you a lot. For example, in prerenal azotemia, urine SG will be more than 1.018. You might have high lean CAS. You have to look for the CAS. Whatever they report, you have to look for. Okay, and of course, urine osmolality is an expensive procedure, investigation, but we do it sometimes. Okay, the progression is generally from ischemia to tubular cell injury to a decline in the GFR, and eventually an intrinsic AKI occurs if you don't treat. Oh, management, we can start off with our management also. Of course, optimization of the renal perfusion. If there is severe blood loss, we have to look into the possibility of a PRBC transfusion. If it is a less severe acute hemorrhage, burns, pancreatitis, we can just manage with normal saline and colloids. Okay, I think we'll stop there because intrinsic AKI is quite extensive. So we will stop there for today. Okay, thanks guys.